This is our final session of what's been a really fascinating day, and we're going to be talking again about regional responses. Delighted to welcome our chair, Michelle Kelly Irving from the University of Toulouse in France. Michelle, if you could introduce your panel for us.
Absolutely. Well, thank you very much. So I'm Michelle Kelly Irving. I'm a social epidemiologist based in Toulouse in the southwest of France, and I work on social inequalities in health. And I'm very pleased to chair this second session on regional responses to COVID. And you can tweet or social media about this session by using the hashtag COVID unknowns if you're interested in doing that. Now we're going to have three different speakers talking about different regional responses. One from representing the African response and two people representing responses in Scandinavia. Each speaker will have 15 minutes, and I will unfortunately rudely interrupt you around a minute before the end in case you go over time, but I'm sure that won't be necessary because you've all been brilliant so far. And I'd like to start by introducing Marguerite Msinga Luembe, who's a senior consultant and laboratory advisor from the Center of Disease Control and Prevention in Africa. And I'll let you take the floor, Marguerite. Thank you.
Thanks a lot, and good afternoon, everyone. So thank you for having me on this panel and giving me the opportunity to share the experience from Africa. And so, as indicated, I am a senior laboratory advisor with the African Center for Disease Control, which is the technical agency of the African Union in charge of global health security on the continent. And I'm also the interim deputy coordinator of the Regional Collaborating Center for Central Africa, which is based in Libreville, Gabon. And if that's okay with everyone, I will turn off my video now because just to have a good bandwidth for my presentation. Thanks.
Marguerite, are you going to share your slides?
Yes, I am.
Real.
Can you see my screen?
Yes, that's great. Thank you, Marguerite.
Okay, thanks. Yeah, so the perspective from Africa on the COVID-19 known and unknowns. So going back to the month of April, May, when the first cases of COVID-19 were being detected in Africa, the predictions were quite bleak, actually. So this was rooted in the inherent weaknesses of the healthcare system in Africa, with really limited healthcare workers available. Also, many shortages as far as hospital beds and ICU units that were available on the continent. It had also to do with ongoing political unrest in some of the country, insecurity, and also a lot of other epidemics ongoing. Just taking the case of DRC, who was faced at the same time with an Ebola epidemic in the Western region, and as well as measles, just to name a few. We ourselves at the African Center for Disease Control at that time published a comment in Nature Medicine where we were warning that actually Africa could become the next epicenter of the COVID-19 pandemic based on the trajectory of the pandemic on the continent, who seem to be heading the same way as the other region, especially Europe. Then looking back now at where we are half a year later, what has happened? Actually, so if I have to state, like the panelists before me, where I was wrong, I think the statement we made in that paper was wrong, and it turned out to be that the situation is quite different as we speak today. And so on the 18th November, if we compare the figures globally with that which is observed in Africa, so Africa, which represents 17% of the global population, is accounting for less than 5% of the cases, with 2 million confirmed cases reported by African member states, and a case fatality rate of 2.4%, which is similar to what is observed globally. And actually, Africa is now being heralded as an example of what can be done eventually to combat the pandemic with a powerful response. But then again, when those numbers were being reported, there were some skepticism at the time, asking about the validity of the data. Basically, was Africa able to detect the cases and to report them properly? And was it just not an underestimation of what was actually happening on the continent? And so just to explain what happened and how the mobilization which led to the response on the continent was organized, need to go back to the beginning of 2020. And when the first cases of COVID-19 were being recorded outside of Africa, the continent was actually quite quick to mobilize under the lead of Africa CDC and the Africa Union. And the Minister of Health met on the 22nd of February, just after the first case was identified in Egypt. And they came together with the African Joint Continental Strategy for the COVID-19 response, which was endorsed by the head of the African Union head of states. And one of the objectives was really to promote evidence-based public health practice for surveillance, prevention, diagnosis, and treatment of COVID-19. And so that strategy was implemented through the African Task Force for Coronavirus. The purpose of the task force was really to bring together all the stakeholders. So of course, Africa CDC, but all the other health agencies on the continent, and notably WHO Afro, the local expertise, which was present in the various countries, the member states, and all the concerned parties. And the African Task Force was organized around the main pillar of the response. So we had the surveillance, the laboratory, infection prevention and control, clinical management, risk communication, supply chain and stockpile. This was really important considering the shortage which was building up globally and the fact that there is very little capacity for local manufacturing on the ground here in Africa. And a last group which was added was the Research Standard and Regulation Group, Technical Working Group. And all of those were aiming to really coordinate, collaborate, and communicate, and to really aim for synergy and avoid duplication, and come up as really one continent in the face of the pandemic. And so to make sure that we were really monitoring the transmission, one of the first tasks that was really tackled by AFTCOR was to make sure that we were capturing all the cases. And one initiative was put in place, which was the PACT initiative, the Partnership to Accelerate COVID-19 Testing in Africa, which was aiming to test, trace, and treat. And so at the beginning of the year, in January, there was no diagnostic capability yet on the continent, as the test was not yet transferred. It was first transferred to the WHO Collaborating Influenza Center in Dakar, Institut Pasteur, and NICD in South Africa. And thanks to really the joint effort of everyone, which I've alluded to before, we were able to train laboratory staff and to make sure that the test kit and supplies were procured or donated, and that they were distributed to all 55 member states on the continent. And we were aiming really to accelerate and scale up at large quick speed, sorry, the number of tests conducted. And by August 2020, there was capacity really to test in all the country on the continent. But of course, as other panelists have alluded to, testing doesn't mean much if it is not also accompanied by the tracing component and the capability to isolate the cases. And so we made sure also to build capacity through the deployment of rapid responder and community health worker in the different countries. And so all of that together, the target of the PACT initiative was really to increase the number of tests to 10 million by October 2020. But actually, we've been quite successful, and we doubled that target with 20 million tests conducted at the end of October, which was putting really the indicator of number of tests reported by number of tests per case reported within the benchmark of the WHO, which is between 10 to 30 cases. The positivity rate is a bit high as we speak, and I will come back to that. And so what happened? What made it possible for Africa really to now that we know that the numbers were representative of the number of cases on the continent, what made it possible to limit transmission? Why were we observing this? And so it appears that Africa has learned a lot from prior experience of prior or ongoing outbreaks, such as the Ebola outbreak. And so, for example, airport screening was implemented by some countries as early as the 2nd January. That was Ivory Coast, and soon to be followed by other countries. So that was before the first case was confirmed on the 14th of February. And shortly after, a country went on with full border closure and lockdowns at quick speed. Also there was already community health workers on the ground for the different disease control program, which could be redirected to the COVID-19 response. Compare maybe to the other region, we in Africa have been actually witnessing high support for public health and social measure, as you can see. So this is a partnership for evidence-based COVID-19 response, which is really gathering the data through a survey of 18 African countries, looking at different aspects of the response. And what has been observed is that actually the population was supportive of the personal measure, and also of the measure to restrict the gathering or restrict economic activity, though as far as economic activity was concerned, adherence might be lower due to the fact that the population was facing financial hardship, especially those in the informal sector, which is a big chunk of the population, and that they had to go and move about to get their livelihoods. So this is what was known, but then what might have happened? So the unknowns of the COVID pandemic in Africa. So what we know is that the population in Africa is much younger, and this might have played a role, considering that the severe cases are more often observed in the older age group. And so if we compare with the other region, as you can see on that graph, really the African population, less than 6% is age 65 or older. So Africa has the youngest population in the world, and also low population density. What do I mean here? Especially if we look at the older age group. So of course we have big cities which are quite dense and with densely populated areas. But as far as the older population is concerned, they are not in retirement homes. Oftentimes retired people go back to the village where the population density is much lower, and the social interaction might not be so intense. There are other contributor which have been proposed, such as exposure to seasonal coronaviruses and maybe pre-existing immunity. The effect also of concurrent infection and modulation of the immune response, which could maybe explain. And also more recently, there has been a body of data which has been published, notably by the team of Professor Akiko Awazaki at Yale University, whereby the effect of climate and notably humidity could maybe play a role to susceptibility to a respiratory infection. So these are all the unknowns really, which might have played a role in the fact that the continent was not impacted as much as others. Looking at seroprevalence, we have now data coming about a serosurvey or limited studies but especially this one from Kenya, which actually indicate that though the number of cases are much lower, the prevalence, the seroprevalence indicate that the immunity is comparable to what has been seen in other areas, for example, in Italy, where the number of cases have been much more. And so can we conclude that the virus is spreading with an attenuated outcome in Africa? Can we really make that affirmation? This is not so sure, because even though the number of cases directly due to COVID might not be that much, we also need to keep in mind that the health system is weak, and all the restriction put in place, the limitation on movement, the fear also of going to the—
You have 1 minute left.
Yeah, might have limited the access to essential services. And so now as we speak, it seems that Africa is entering the second wave. Though we had time to prepare in the meantime, we need not to be complacent. And so we are really promoting the use of data to support the decision-making. And also we are aiming to provide access to intervention. So here we have the example of all the guidelines that Africa CDC has been publishing and sharing with the member states. And the fact also that we are helping with distribution of drugs which can help with management of patients such as dexamethasone, but at the same time making statement against the use of hydroxychloroquine, for example. And the next challenge for Africa will be access to vaccines. So this has been discussed. We want vaccines which are context relevant. So we are trying to promote really clinical trial done in Africa. And so here you have an unexhaustive list of the vaccine being evaluated in Africa. But even though, for example, the Pfizer vaccine has been evaluated in South Africa for the various reasons which have been mentioned by other panelists, we are facing huge challenges, one of which having to do with the cold chain, for example.
Thanks
but against all odds, this is my last, please, if I may. So what happened 2 days ago is that the Ebola epidemic, which was ongoing in Eastern DRC, has been declared over, because I think this is demonstration that Africa can learn from past experience, and when coming together, we can achieve resilience, which is enabling us to respond to the COVID pandemic. Thank you.
Fantastic. Thank you so much, Marguerite. Perfectly timed. So now I would like to invite Camilla Stoltenberg, who is the Director General of the Norwegian Institute of Public Health in Norway, to take the floor with her presentation. Go ahead and share your slides, Camilla. Thank you.
Thank you very much for inviting me. I just share my slides and then I'll start. Can you see them now?
Not yet.
But I'll start speaking anyway. So tell me if you don't see them. I'll manage without, but
we don't see them yet.
No, can you try sharing the screen again?
Mm-hmm. Should I try again?
Yeah.
No, it doesn't respond. So I'll just do it without the slides, but that's going to be fine.
I can share slides for you if you send them to me, if you prefer, whatever's easiest for you.
I think I'll be fine without, so we can just start, so we won't lose any time.
You go ahead, Camilla.
Yeah.
Thank you.
Thank you. I see them myself, so I can use them, and that's fine. Norway had a wave in March, April, as many other countries in Europe, and at that time, we believe through mathematical modeling that we discovered about 10% of the cases out there. Now, after having implemented measures from March 12 onwards, we had a rapid decline and enjoyed a long summer from May actually till August, September, with a very low incidence, around 20 cases per 100,000 per 14 days. Now, since the end of October, we've seen a new surge and we're in the second wave. So we do not know whether the new measures that we've implemented will work this time. But we do see some signs that the curve may be flattening, but we still don't know. So the pandemic is definitely not over in Norway, and we shouldn't boast ourselves with good results. But so far, we have placed ourselves somewhere between New Zealand and Sweden when it comes to cases per million people. 5,675 cases per million is what we had by 20th November, compared to 344, much lower in New Zealand, and 19,907 in Sweden, much higher. So we've also had deaths between New Zealand and Sweden somewhere, with 56 deaths per million people, compared to 5 in New Zealand and 628 in Sweden. Our overall mortality is not affected, and altogether there have been just over 300 deaths. We have tested many people and are now ranked as number 19 when it comes to how many we've tested per 1,000. More than 2 million of our 5.3 million inhabitants have been tested one or several times. Between 1,100 and 2,000 people are working on contact tracing all over the country in each municipality, and there are more than 350 municipalities in this very long country. So, what characterizes Norway's pandemic response? Here I would like to show you a picture from the 12th of March, when there was a press conference with the Director of Health, Bjørn Guldvog, the Prime Minister, Erna Solberg, the Minister of Health, Bent Høie, and myself, the Director General at the Norwegian Institute of Public Health. And this picture is in a way expressing how the response has been led by the government. And a key feature of Norway's response was that the government got involved very early and showed leadership, and have kept that leadership continuously ever since. There was an abrupt and comprehensive set of measures that were put in place on March 12, including border control, restrictions on mobility and social contact. And the first confirmed case was on 26th February, just about 2 weeks earlier. The first death was on that very day, the 12th of March. And on the 10th of March, 2 days earlier, the first cases that could not be traced to travel abroad were confirmed. So we believe that the measures were put in place as a package with a very strong political leadership at a relatively early stage. The government has collaborated very closely with the Norwegian Directorate of Health and the Norwegian Institute of Public Health throughout. Our institute is the scientific advisor for the government, but with networks in all the academic and scientific institutions in Norway. By March 24th, the strategy changed, but in fact, it had been implemented even before that. But then it was expressed explicitly that it changed from mitigation to suppression, and that the aim was to push the R below 1. On May 7, the formal announcement of a strategy to keep the pandemic under control was put in place. The government said that the government's strategy is to deal with the COVID-19 pandemic in a manner that enables us to control the spread of the infection at all times. Control means that the burden of disease is low and that the number of patients is manageable in the health and care services. Now, the recent surge in cases has led to new strict measures that are implemented, at least in some places, and particularly in the capital of Oslo. And it's still too early to say whether they will be effective. So what do we think may be the strengths of Norway's pandemic response? That it was abrupt and comprehensive, that many measures were put in place in one day, that the political leadership was clear, and that they used legislation actively to introduce social distancing measures. So they didn't just provide advice, which was what we are mandated to do. We can only provide advice from our institute. We cannot use legislation unless, but we can advise the government to use legislation. There was a high level of public trust, and there is a high level of public trust in government, authorities, and bureaucracy, and there's a comprehensive social safety net. And we have institutionalized scientific independence and openness about unknowns and uncertainties regarding the evidence lying under our advice. So my main focus in this presentation is actually not on what exactly happened, how many cases we've had, what precise measures we've been using, but on the way that our institute has been trying to shape the role of ourselves and others as scientific advisors in crisis. We have been very clear on our scientific independence, on the need for scientific inquiry and new knowledge in the pandemic, on the shortcomings of the science, so that the politicians cannot say that, well, our scientific advisors said this, so that, therefore it is scientific. And we have been communicating shortcomings and uncertainties continuously throughout the response. Earlier, that has been considered to be sort of exposing weakness, while now we have experienced that that has been considered a strength. And slowly, that has these approaches, the approach that we need transparency, openness, freedom of speech, we need participation, we need increased literacy on, or increased scientific literacy in the media and in the public in order to handle such a crisis. That has grown up as one of the characteristics of the response in Norway. And these approaches have now been embraced virtually by, or at least by almost everyone, and there is very little criticism. In the beginning, there was quite a lot of criticism, but that has abated and almost disappeared. It may, of course, return. Nothing is over yet, but it's been a very interesting experience so far to see how this has developed and how we've managed to continue to collaborate well with the politicians, recognizing our roles and recognizing the uncertainties of the evidence. So, what are the main unknowns? We think that it may not be considered an unknown because it's too general than that, but there's an enormous need to design a system in which one considers that scientific approaches in design and evaluation is a part of how you operate when you design the response, when you decide on interventions. That is to some extent the case when it comes to drug development and testing. It is certainly the case when it comes to development and testing of vaccines, but it is not the case when it comes to all the other interventions, the so-called non-pharmaceutical interventions, the societal interventions, those interventions that are aimed at individual behavior and those interventions that use legal measures. So unless that happens, I believe that it will be very difficult in new waves or in future pandemics to be able to get the kind of trust that we now get from the public. So hopefully that will become a demand from people and from politicians, while it's still a division between science and response under crisis that is too big and where there's a gap that we really need to fill. So other more practical unknowns or things that we need to work on are how to balance effect and burden of interventions when knowledge about the social and economic burden of interventions is so limited. And that is particularly visible, I think, when it comes to the added complexity with regard to subgroups of the population, and in many cases that means immigrant groups. And it's also important to, at the moment, reconsider whether we have to have a new look at what's happening in schools among young people, because in this new wave we see that first there was a big increase in the number of young adults that had tested positive. Now we see that even younger people, teenagers, are dominating. They are actually now the groups with the highest incidence. Then before ending up with some concluding remarks, I also want to share some reflections on the role of a project we had on trying to establish a contact tracing app. We actually did that with collaborators in the UK, and we did it at a very early stage, even before the interventions in Norway, or before the public in Norway really realized how serious the situation was. So on 9th March, we decided that we should try to develop an app for contact tracing very rapidly. And to make a long story shorter, privacy concerns halted the implementation. And the main arguments against the app were that it was using, or that we had planned to use data for contact tracing and for analysis to understand and follow and intervene on the epidemic at a group level, at a population level. And those were considered two different aims. So the authorities on data security, they demanded that we should separate the informed consent and also separate the storage of the data for those two purposes. So the collective purpose, the analysis of the epidemiology, that was not considered useful for those who had downloaded the app, although it was completely voluntary and based on informed consent. So in the end, we couldn't do that. And now we're developing another app where we cannot get data for such analysis. And my question is, why is it considered to be so much more dangerous to store data a few days in a country where there's complete transparency? Everyone can retract their own data at any time. They can even turn off the app if they don't want it to function. That's considered to be a very grave intervention in people's privacy, while to give the same kinds of data to large global data companies, data-driven companies, that is possible based on informed consent. So to end this presentation of the characteristics of the response in Norway, I will say that our main aim at the moment is to make research and innovation a much more integrated part of crisis response, not something that comes afterwards or that doesn't happen at all if the urgency is too big, but something that is fully integrated in response. It's hard to do it while it's ongoing, but now we have the opportunity. Thank you very much.
Thank you very much, Camilla. That was fascinating and also perfectly timed. So brilliant stuff. Thank you. I'd like to now invite our last speaker for this session, Johan Giesecke from the Karolinska Institute in Stockholm in Sweden, to provide us with his presentation. So you can go ahead, Johan, and share your screen if you have some slides.
I have slides, but it's very small. Am I sharing your slide, your screen?
you should share your slides using the share screen function.
I'm doing that. And all I get is, I think, is your screen.
Yeah.
Yeah.
I'm not sharing anything. Oh, here we go. We're seeing your screen now.
Okay. But where is the presentation?
I think if you minimize the tab that you're on, I think you're on Safari of Zoom. If you, in the top left corner, if you minimize.
Quit Zoom.
No, because then you'll leave the call. This, just below there's those 3 dots. Yeah, just here, there's in the top corner, there's 3 dots.
There.
Just above that.
There.
Above that. The red, yellow and green dots. If you press the yellow dot.
Okay. And
wherever your PowerPoint is.
Nikki, do you think you could help me with
this? I can see your slides on your desktop. If they're there, you can just lower down and slightly to the right.
There.
Lower down and slightly to the right, your slides. Can you see them? There. Do you want me to do it? I can share screen. Okay.
The one. Sweden Giesecke PPT. Yep. That's the one you want to double click on. Where you were just now.
There.
That one, yeah. Go for it. Yeah.
That's it.
Ah.
There you go.
Sorted.
So if you make that big for us.
Yep. Voilà.
I'll leave it.
Thank you very much. Thanks, George and the BMJ and others for inviting me to this very fascinating and interesting meeting. I will talk a little about the Swedish response, because Swedish, it should be response, not response. Because Sweden is often seen as an outlier when it comes to control of corona pandemic. And I will try to show that even though there are some differences, in the end, the outcome isn't that different. And actually, I met a professor from Scotland not long ago, Professor Woolhouse, who said that if you take the Scottish epidemic and overlay the Swedish one, they're exactly the same for the people in the UK. Okay. Health and healthcare in Sweden, just a bit about the background. Population 10 million. We have 20% over 65 years, which is quite a lot more than in Africa. Low maternal and child mortality, decentralized healthcare system, and that plays a role actually. Sweden is centrally controlled in many ways, but when it comes to healthcare, it's quite federal, and I'll return a little to that. And healthcare is publicly financed and subsidized. There's a Communicable Disease Act that was written after SARS. Like I said, the 21 regions are quite autonomous. There's a high level of trust between public authorities and citizens, and that plays a big role. The Public Health Agency has a wide remit, not just infectious diseases. And that's interesting over Europe, because the agencies are sometimes just for infectious diseases in some countries, and then they're for public health in general in some countries. And I think that has a bearing on the work and the recommendations that come out of these agencies. It would be nice to study that actually, what difference it makes, if you're a pure public health or if you're just infectious diseases. We have about 200,000 confirmed cases. We have 3,000 people have been in ICU, 6,000 people, a bit more, have died, many of them in nursing homes. And we have an increase in summer, but as a difference from what happened in March, April, May, the proportion of this is much less than it was in spring. We have a higher number of fatalities compared with neighboring countries. Norway, for example, is a good example, and the reasons for these are unclear. If you compare to other European countries like Belgium, France, UK, the difference is not that big any longer when it comes to fatalities. This is test positives percent on the left-hand y-axis, and week from March until last week on the x-axis. The green, don't care about the green. That was a special reporting requirement for a while. But you can see that almost 15% of people tested are now positive. This is the same length from March till now. The red line on top is the old people who were the first cases. And then you can see at the right-hand end that now people between 20 and 60 are becoming the big group with the biggest number of cases. Cases per week going up quite rapidly over the last month or so, after a sort of honeymoon during summer and in early autumn. Cases in ICU, the same thing, and deaths, still, like I said, the proportion of people who die is quite a lot lower than it was in spring. How it's managed, this pandemic. Minimizing transmission is the overall goal. Protection of risk groups is also the overall goal. It's important for us that we have sustainable strategies for response, that we don't have to change. Now there's a lockdown, now there's not a lockdown, now you can travel to country X, now you cannot travel to country X, but to keep the same strategy over time and not go back and forth. There's a combination of binding regulations, like in all countries, and more voluntary measures. We do believe that people will understand what's good for them. You don't have to write new laws, you don't have to have police in the street. If you tell people that it's good for you to stay at home, not go to work if you feel sick, meet in as small groups as possible and so on, most people will do that, and I think that's not unique to Sweden. Evidence-based as much as possible, we're trying to do that. Some examples, there was a ban on visiting nursing homes, which is now allowed. Distance education for secondary schools and universities. Bans of gathering of more than 500 people first, and then down to 50 people, and now it's 8 the last few days as a new ordinance. Physical distancing enforced in restaurants and cafes, but they're still open, and travel restrictions and entry ban. Recommendations to the public: stay at home if you're sick, even with minor symptoms. If you're over 70, stay at home as much as you can. Avoid unnecessary travel. Work from home. Avoid public transport. Meet as few people as you can. Keep distance. And basic hygiene, of course, with frequent hand washing and so on. The public response, just like Camilla said about Norway, is very positive in the Swedish population. There have been several questionnaires sent out to people, and 80% follow the rules without, like I said, laws or police. And there's a high level of public trust in the public health agency and a high level of compliance with recommendations. So it's recommendations, not restrictions. But the difference, if you look at it, isn't that big actually. And schools have stayed open. So that schools up to age 16, they've been open all the time. Like I said, secondary education and universities have partly been closed. And the reason for keeping schools open is, like who said that, one of my predecessors, that you keep a structure in society, which is quite important, I think. And children do not, at least children up to 10 are not driving the pandemic. And there are other negative health effects from closing schools, and children rarely get serious ill. The schools have been open. Face masks is the eternal, perennial discussion. Of course, medical face masks are important, that's no discussion. And we say that because there's a high level of compliance with physical distancing, plus weak evidence of public use of face masks. There is no recommendation to the public at present, other than when you come into a situation where you cannot avoid coming too close to other people, then you should wear a mask. But in general, in public and outside, you're not obliged to wear a mask. Some people do, but there is no restriction to do that. But if there are local outbreaks or in situations where crowding cannot be avoided, we recommend using face masks. Key points: the containment and mitigation measures in line with other countries, adapted to the Swedish government structure and system. And like I said, most of them are voluntary, some are not. there's a high level of trust between the population and the authorities, and the compliance with the recommendations, even though their own recommendation, is very high. And we are, the final thing, that we are still in the pandemic, that too soon to evaluate measures. I don't think we should compare countries yet. This pandemic isn't over, and the actions taken by different countries, that will, maybe we'll have to wait a year or maybe longer before we can really see what is the pros and cons of the different actions taken. Even though we now have many examples from different countries in Europe especially, it's too early to say that this was a good restriction and this was a bad recommendation. That's my feeling. Too soon to evaluate measures. We should wait for that. Future, balance between as few restrictions as possible and not overburdening healthcare. That's important, and that's all countries have that problem. Improve clinical care. I think that's very important. One reason that mortality is lower now than it was in spring is that we know much better how to treat the patients, and there are drugs and way of taking care of them. So I think healthcare has improved quite a lot over the last 6 months. And then we have the vaccines, and I am a bit dubious on how long it will be before we can start vaccinating large groups of people. The vaccine is coming, it may even come this year, but before we have vaccinated all people who need to be vaccinated, I think we'll have to wait for a long time. And that's it. Thank you very much.
Thank you very much, Johan. That was very to time. And I noticed that the bong of your clock synchronized perfectly with the gong of the church just near me here in Toulouse. So we're very well synchronized in time. Yes, if you wouldn't mind sharing your screen, and that way we can see you when we go to questions. We've had some nice perspectives. One example from across African countries and what happened over there, and then 2 different examples from Scandinavia, one Norway and the other Sweden. As far as I know, Ben has been collecting your questions that have been coming in. So perhaps, Ben, you would like to, I think it's Ben, is it?
Yeah.
Yeah.
So one question I think in particular for Marguerite is, have the efforts and resources deployed for COVID had a positive impact on any other conditions? Are you seeing that in your data at the moment?
Yeah, thank you. That's a very good question. And actually, it might have been the other way around. Because what happened is that to be able to ramp up so quickly, for example, diagnostic capacity or even hospitalization facility for the patient, we had to leverage and repurpose what was available. And so we might have ended up in some cases in really redirecting services towards COVID-19, and then by ricochet, we say in French, the service is not being available anymore for TB, for example, or HIV. And so I think for Africa right now, the next challenge is really to make sure that access to essential services is being maintained. And also, as the pandemic will hopefully go away, the question is really what will happen of all that capacity which has been put in place. Surely the reinforcement of the human workforce is here to stay, but we have to see what will happen, for example, of all the lab facility which has been put in place. Yeah, thanks.
Thanks, Ben. Do you have any more?
Yeah, so more, I think a question for Camilla. And you mentioned in your talk about the indirect effects of COVID and the need to think about these, and it's a big unknown. What form do you see, or the studies, what studies would you want to undertake to look at these, and what form would you see them taking?
I'll answer that question on at least 2 levels. One is the response when it comes to interventions that are aimed at reducing serious disease and death is institutionalized and planned for. and it's even international, and it follows a set of sort of rules and has its own networks and plans. But there are no plans in place for how to assess the indirect effects, if you want to call it that, or the burdens, those plans have had to be invented along the way. Now, of course, there is a lot of research that has been initiated, but it's not systematically done, both at an expert level, at an institutional level, and at the scientific level. In fact, it's done more so at the scientific level than at the other levels. Those are more ad hoc. And I think that one should, in order to have a true balance, think about how that whole setup should be with the other sectors involved when the crisis actually goes across all sectors or several sectors, as in this case. It's not contained within the health system. So that was a very general response to that, but I think one does need to have a system in order to balance it truly, or else it won't work.
You want to go ahead, Ben, with another one? Are there any for the Swedish example?
Yeah, the one question that's come in is with regards to Sweden. Was herd immunity ever the openly stated goal of your policies?
No, neither openly nor covertly. It was never a goal. The goal was to protect the old and the frail. And if you do that well, you may have, if you're lucky, as a side effect, that you get some kind of herd immunity. But it was never the objective, openly or closely.
Would it be okay if I asked a quick question? So coming from the French perspective, I work in France where public trust is a huge problem, and we don't have what both of our speakers from Scandinavia mentioned, which is compliance and trust between the general public and the population. And I wondered whether Marguerite had any examples from the different African countries that you've worked with about this issue of public trust and compliance.
I think, well, the example we can take is the one which is upcoming for us, which is the one of vaccine. We had a huge, a huge situation with vaccine at the beginning of the pandemic. It had to do with a repurposed BCG vaccine, and it created really a lot of reaction on the continent, with people perceiving Africans as being used as oh, I'm sorry. Now I just have the word in French in my head. Guinea pig, yeah, that's the one. And so we are trying to address this as we are moving towards vaccine approval and distribution and rollout. And so, for example, we are currently doing a CAP analysis, CAP study to see what is the perception of vaccine in the population currently. And also we are planning to have a framework really to engage with the communities around everything having to do with vaccine acceptance. So that's one example. And it's been also demonstrated there was a lot of mistrust around the Ebola vaccine in DRC. But on the other hand, I think the demonstration has been made that it was quite effective in fighting the epidemic at the same time. So yeah, but it's a continuous engagement, of course.
Thanks very much. Would either of our other panelists have any comments about trust based on Norwegian or Swedish examples?
Yeah, I can.
Yeah.
I think it's very hard to create it when the crisis is a fact. You have to have it in place beforehand, and you also have to work on it continuously during the crisis. But of course, it does help for Norway that the social safety net is so comprehensive, so that even people that are laid off manage, because when people are more directly threatened when it comes to their livelihoods and not only their personal freedoms, I think that's a very big challenge against trust, and also societies that are much more diverse, we may have problems in communicating with all groups. So one has to use a lot of resources and creativity in establishing that communication. For example, to be able to test in certain groups, or to make people trust you when you do contact tracing, for example, which is may seem very similar to being sort of a detective or a police, but it's not.
That's true, and that's also a general comment that's true, which is trying to change everything during a crisis is really maybe not the best time to bring in new measures. Johan, would you like to add anything?
No, I think I'm okay.
Okay, we have a couple of minutes left. Would Ben have any more questions coming in from the Q&A?
I think there's a broad theme about the economic effects of these interventions and whether Sweden has got that right. How has Sweden thought about factoring those in to the public health measures that's been done?
Now I don't understand what you mean. Sorry,
how much of a consideration is one considering about the economic impacts when thinking, or are you purely focusing on health first? And
yes, first. I mean, keeping the schools open has some kind of long-term economic benefit. There's a study from Norway that Camilla knows more about than me. The money you lose from being locked out from school for a couple of months, how into the future, how big a role that plays actually. But economy hasn't really played any role in this. There is, and like in Norway, there's a safety net, social safety net, so that if you're laid off or if you have to stay at home because you may be infectious and so on, there is a compensation for that.
And any more questions, Ben? Otherwise, I have one coming in that I've seen on the chat, which is about housing and to what extent in each country you might have had examples about housing being an important driver of potential transmission, and were any interventions or thoughts given to intervening with regards to housing. Perhaps Marguerite, do you have any thoughts in your examples?
I'm very sorry, I was responding to a question on the chat. Can you please repeat?
No problem. It was to ask you whether you have any examples from your research around housing, and whether any interventions were set up or put in place to perhaps deal with overcrowding or transmission that might be happening within the home. Do you know of any of those?
No, I'm not aware. So this is something which has been highlighted, the fact, especially in some slum areas, that the people are really living in crowded condition. But then at the same time, I think in Kenya, they looked at that, and what seemed to happen is that there was transmission ongoing, but yet again, you know, the number of severe cases, they have not been so high in Africa. So basically, it's like, there is, so this is modeling, it's a preprint by Ojol and colleague from Kemery, which is quite interesting, which seemed to indicate that there was up to 30 to 40% positivity. So it seems that transmission is ongoing, but it mostly would be post-symptomatic cases. So that's what I can say about this. Thanks.
Thanks. So we know, for example, in France that in the first lockdown, the seroprevalence in the population was in and around 4.5%. But for people living in overcrowded conditions, that seroprevalence of COVID went up to 9%. So there was definitely evidence of overcrowding affecting at least your likelihood or your risk of infection. So that's giving us some ideas about inequalities. So do we have any more questions, or otherwise I'll hand the mic back to Phil, I think.
Yes, thank you, Michelle. That was wonderful. There was a great phrase about the pandemic that we may all be in the same storm, but we're on very different boats. which I think is true. Wealth is the best protector for just about every disease, both communicable and non-communicable. And it's really interesting that the countries that had a big social safety net, I think that engenders trust. You know that the state has your back if the worst happens. And I think we can all learn a lot from that. So some fascinating perspectives.